Hello, everyone. My name is Dr. Richard Horowitz, and I'm your co-host from the Healing from Lyme Summit. It's my great pleasure today to have you meet one of the greatest neuroscientists and leading researchers in Alzheimer's and neurocognitive deficits in the world, Dr. Dale Brederson. So, Dale, I'm just going to read a quick bio. It would go on forever. You have so many accomplishments at this point. Let me just give people a quick overview. You're an internationally recognized expert in the mechanism of neurodegenerative disease, such as Alzheimer's disease. You graduated from Caltech and got a medical degree from Duke. And then you've been working in your laboratory studying the basic mechanisms underlying neurodegenerative diseases. You have over 200 research papers, and I know now you're doing randomized trials on Alzheimer's. So since my Lyme patients are all cognitively impaired, I think you and I may have some interesting discussions to have about what you and I have been doing and kind of how they overlap. So thank you for doing this today. It's really great to see you again.
Absolutely. Always great to talk to you, Richard.
So why don't you talk a little bit about the relationship of what you're seeing in your practice? I knew you and I share a lot of overviews. We have a multifactorial model, right, for basically cognitive dysfunction. Can you share a little bit about your background, how you got into doing what you're doing, and where you think the overlap lies with Lyme and tick-borne and kind of some of the models that you're seeing at this point?
Yeah, such a great point. So, this really gets into how medicine has been mispracticed for the last, hundreds of years, where we focus on one thing. We say, okay, we're going to give a drug to fix this. We spent, as you said, many, many years in the lab. We had the 30 years I ran a basic neurology lab looking at what drives the phenomenon of neurodegeneration, whether it's Alzheimer's, whether it's frontotemporal dementia, ALS, Lewy body disease, right? This is the area of greatest biomedical therapeutic failure. As people say, everyone knows a cancer survivor, no one knows an Alzheimer's survivor. So we, as you know, reported the first examples of reversal of cognitive decline back in 2014. We published actually another 100 back in 2018. We published a successful proof of concept trial last year. And now this year, we're working on a larger randomized control trial. But here's the thing. What we found in the lab fits beautifully with what you've been doing for your patients and what we are doing as well, where what it turns out is what we call Alzheimer's disease is fundamentally a network insufficiency. You have about 500 trillion synapses inside your skull. It's amazing. Got this amazing supercomputer. It has its own supply. It has its own demand for different subnetworks. There's a neuroplasticity subnetwork. There's a motor modulation subnetwork, which is what goes awry in Parkinson's. There's a power subnetwork, which is what goes awry in ALS. Each of these subnetworks has a supply and a demand. And when the supply starts to go down and the demand starts to go up, it starts to involute. Literally, it's now have to pull back. And so with Alzheimer's, of course, the first thing we see is you can live with the memories you've made over X number of years, whether it's 40, 50, 60, 70. And of course, the big increase in Alzheimer's is in the 40-somethings and the 50-somethings in the last 10 years, sadly. We used to think as a disease of the 60s, 70s, 80s, 90s. We now know this is starting for people in their 30s. You can see changes with these new blood tests. Now you can see changes very, very early on. So what happens then, the main drivers of Alzheimer's disease are three. It's anything that reduces energetics. And so that's mitochondrial compromise, as you well know. It's reduced blood flow. It's sleep apnea. It's any of those things that are reducing the support to your brain. The second thing is anything that increases an inflammatory response, which is why, by the way, ApoE4 is such an important risk factor. It is a pro-inflammatory gene, and that is tick-borne illnesses, incredibly common. Mycotoxins, incredibly common, as you know, and these things run together so commonly, as you know. Change in the oral microbiome, some mild chronic sinusitis, a leaky gut, a poor metabolic syndrome with a high hsCRP. These things we see every day. And then the third thing, of course, is toxin exposure. And actually, I would love to hear from you. Certainly, we know that there are toxins associated with mold species. But I've read both sides. To what extent are there actually toxins being produced by these tick-borne illnesses?
There are. It's a great question. And I've got a couple of follow-up questions actually for what you just said about this, because the 16-point MSIDS model that I use, it's exactly that. We look at the microbiome, we look at leaky gut, we find mast cell, we find all these infections, we find toxins. The Lyme patients don't sleep, right? And a lot of times they have downstream effects, including mitochondrial dysfunction, POTS dysautonomia, hormone dysregulation, right, et cetera. So I mean, the model is pretty similar. And regarding toxins, we do see that these toxins do affect cognition. Borrelia was published a couple of years ago. Most people don't really talk much about it, but there have been some studies on quinolinic acid, that have showed up in some of these patients with tryptophan metabolism. Clearly, that it is a problem in some of them. There was one that Dr. Dante used to talk about years ago, BB-Tox1. Now, interesting, there wasn't a lot published on this in the last couple of years. Most of the stuff we're seeing now with toxins relates to heavy metals that either I'm finding them in the bloodstream or, occasionally doing a 6-hour urine DMSA. But you're right about mold. I mean, the last paper we just published, it was 84% of our people were exposed to mold toxins. And the problem is it does cause cognitive dysfunction with fatigue and a lot of the overlap of the Lyme symptoms. So you're finding, how often are you actually looking for the mold toxins, these toxins in your dementia groups here?
Oh, we look at it in every single person.
You do.
And you could argue that it's one of the most common contributors. So, I've really come to believe that we're all exposed to some level of this. So some people are exposed to a very low level, great. Some people it's intermediate, some people it's very high. And then everyone's got a certain amount of ability to continue to detox. So as long as you're keeping up with that, you're in pretty good shape. When you're behind on that because of genetics, because of what you're eating, because of the exposure is higher, because your glutathione is low, because you're poor methyl, whatever it happens to be, of course, these things are starting to increase and increase. And now you really run into problems. And yes, I think part of the problem is these are dynamic neural networks. And so what happens is when you are you're on the losing side here, things are just getting worse and worse and worse. And this is why you really have to change. You've got to change the exposure, reduce it. You've got to improve the ability to detox. And I think this is also why you see these things running together so much, because when you have either one of them, a tick-borne illness or you have mycotoxin exposure, it reduces your ability to deal with the other one. Mm-hmm. And so what we do in our treatment and what we've done since the very first patient we reported, the first patient was April of 2012 came to see me. And I said, look, I haven't seen a patient in 20 years. I'm a lab director. What are you doing? And she said, no, I heard you guys are doing something different in Alzheimer's disease. I said, well, look, we just got turned down to do a multi-pronged approach for people with cognitive impairment. If you want to go back, the IRB had said it's too complicated. We're not going to do this. So I just gave her the list. I said, look, here, you can go through all these things. So she called me 3 months later and said, I can't believe it. My memory's better than it's been in many, many years. And I'm so surprised I'm better. And I thought, okay, we're on the right track. And now we've had over 7,000 patients who've now gone on the protocol. And yes, all we're really doing is we're decreasing the side of the demands and we're increasing the supply. Duh. We're just basically trying to improve that dynamic interaction, that situation. And for so many of these people, I know Kat Toops, whom you know, Dr. Kat Toops, was part of our first trial and, by the way, got great results with her patients. She's also part of our second trial. She pointed out that in her initial 10 patients, 4 of them had tick-borne illness. So I mean, that's a lot of people with Alzheimer's disease. We're looking at the statistics say that 45 million of the currently living people in the United States will die of Alzheimer's. It is an incredibly common problem. And
45, because I've seen that it's preclinical dementia. I've seen that number around 46, but actually 45 million that will die with it.
Well, that will get it. So it's about 15% of if you just do serial autopsies, it's about 15% of the population. So it's incredibly common. And yes, I think tick-borne illnesses are one of the most important, one of the most often overlooked, and one of the poorest treated entities that contributes. We see sleep apnea. We see changes in the oral microbiome. We see mycotoxins. The mycotoxins, by the way, are the other tough one to treat. We see vascular disease. And by the way, people respond beautifully to EWOT, exercise with oxygen therapy,
Mhm.
when they have vascular problems. This is one of the things that really gets people to improve. They respond beautifully to improving their insulin sensitivity. Richard, one of the interesting things to me, as a neuroscientist in the lab, if you look at what it takes to power a neuron, and of course, your brain takes about 20% of the energy of your body, it's a tremendous amount of energy. There are only two things the brain can burn. It can burn
Ketones
glucose
and sugar.
and it can burn ketones. That's it. And so what happens to many people, most of the people I see, they've lost the ability for both of those. They have insulin resistance, so they're no longer able to burn glucose very efficiently. And now what happens is, because you have high insulin, as you're pouring out, you've got this insulin resistance, it prevents you from making ketones. So they've lost both sides. So I consider it an energetic emergency when I see someone with cognitive decline. And if you look at all people with cognitive decline, the number one in terms of continued decline is Alzheimer's. But I think you're right. Brain fog from things like COVID and tick-borne illnesses is really becoming exceedingly common. So what we have to do then is we have to get back the insulin sensitivity, which we do with a plant-rich, mildly ketogenic diet. And then we have to get back the ability to make ketones. And at the beginning, we just give some exogenous ketones, but now slowly move them into endogenous ketosis. And this combination makes a huge difference.
Yeah, there's just an article, I just read it this morning. They were talking about, for those people that can't do, real intermittent fasting for 12 to 16 hours, that if they did 5 days a month, I just read it this morning, and they managed to get a very low caloric diet, and they could reset the insulin receptors. For someone like myself, I've always been looking to, like, the way I still work, I'm still working hard as you are. It's not so easy to do a full, intermittent fast for 12 to 16. I've done it. I've tried it and it did work. I just needed to skip breakfast ultimately. But
Yeah.
have you seen other ways of reversing this? Because obviously you can give ketones and kind of do it, but do you think that there's maybe some merit to just basically a couple of days a month like this with a very low caloric diet to try and reset the biological clock a bit?
Great point. So there are a couple of key caveats there. And so I know Walter Longo very well. Walter and I go way back. We published a paper together at UCLA when he was a graduate student and I was a beginning assistant professor. Great guy. And of course, he really developed the fasting mimicking diet, which is a diet that it really doesn't trigger your mTOR. And so you can do that. Now, here's the issue. And there are two of them really. One is, if you are frail, if your BMI is 18, and we do see a lot of people with cognitive decline who are frail. And so you got to be very careful. And I see them often with fasting, they will do worse instead of better. The ones that are the BMIs of 26, 27, 28, those are the ones where it's easy to do the fasting and they do great. And they get insulin sensitive again, they make ketones again, everything's great. We give them the exogenous ketones just at the beginning to help, because again, you're dealing with a situation where the neurons have simply not had the energy they need for quite some time. And of course, Professor Stephen Kinane from Canada showed that giving people exogenous ketones who had MCI improved their cognitive scores. But the issue with fasting mimicking diet, what Walter has said is, and I think it works very well. He's had great results, for example, with cancer, with getting this fasting to improve outcomes in cancer treatment. And so his thing is, okay, go ahead and do the 5 days, and then you can go and kind of have a regular diet. Our worry is, if you go right back to a standard American diet, you're going to hurt yourself. So I would say, sure, start with a fasting mimicking diet, especially if your BMI is above 25. But then please don't go back to the standard American diet, because that's what got you here in the first place. So please stay. And you made a good point. If you skip breakfast, you skip one meal a day, you have 2 meals a day, you're going to have typically 12 to 16 hours of fasting, and it's not really a problem. And measure your ketones. It's easy. You can do it either with a finger prick method and measuring your BHB. You want to get it over 1.0 millimolar, or you can do it with a breathalyzer if you want to. There's a nice Biosense breathalyzer, for example. You want to get over 10 ACEs on that one. And just if you get there once a day, that's great.
So regarding the energy requirements, and by the way, our chronic Lyme patients also, they don't do well with sugar for many reasons. Number one, half of the patients who come to me have metabolic syndrome and they
Right.
swing their blood sugar with reactive hypoglycemia, but the bugs obviously feed off sugar. And, we're not giving them long courses of antibiotics anymore, but candida is still an issue, right? We have to be careful. So if you don't address the underlying sources of inflammation, right, you don't kind of pull out the toxins, deal with the infections.
Right.
Is it still possible with mitochondrial support? Because you were talking earlier about, the energy requirements, and I know they're looking at this now, that it's not just a question of these tangles in the brain and the amyloid plaques that's the problem, but it's also an issue with the mitochondria, even using low-dose methylene blue to stimulate it.
Yeah.
Can you get beyond that with mitochondrial? You really always have to get to the underlying sources of infections and the toxins for this to really work.
Great point. And it depends on where you are on that supply versus demand. Now, what happens is, as long as you have ongoing inflammation, and you mentioned mast cell, and there's microglial activation that's very well described in Alzheimer's disease, then you increasing that demand. And by the way, what is amyloid? Amyloid is part of your innate immune system's memory component. And as you know, the innate immune system, the evolutionarily older part of your immune system, the less specific part of your immune system, lives in three places. It lives in your bone marrow. So if you're doing all sorts of saturated fat and stuff, you're going to have this hyper response. It's basically saying you've had insults, I'm getting ready for another insult. It lives in your endothelial cells, which is why you have this increased thrombosis in long COVID. You see it with Alzheimer's as well, which is why we like to use nattokinase for many of these people. This hypercoagulable state associated with inflammation. And then, of course, the third place it lives in your tissue macrophages, which in the brain, of course, are your microglial cells. So if you're kind of right there on the border, yes, you can get away with just supporting the mitochondria and goosing up the energy, doing some EWAT, getting a good plant-rich, mildly ketogenic diet. However, as you well know, if you have a big exposure to mycotoxins, or you've got a lingering Lyme disease or other diseases, then you're going to have to do more. Now, interestingly, Dr. Christine Burke, another person you know well, Christine showed that if you do the basics, if you do the diet, exercise, sleep, stress, brain training, detox, and some targeted supplements, the basics, what we think of as the basic 7, you get improvement for about 9 to 12 months. That buys you the time to look to see during that time, is there Borrelia? Is there Bartonella? Is there Babesia? Is there Ehrlichia, Anaplasma, what have you? This is so common we see, especially with people who kind of have these relapses where they do well for a while and now they start to go downhill. That we often find these. And I have to say, Richard, one of the toughest things for us is having people do the right tests. They just say, oh, I did a quick test on blank, whatever it is. And then, there didn't seem to be much. So I don't think they have tick-borne illness. And, meanwhile, the person is just continuing to go down. And I was like, wait a minute, this is a terminal illness, Alzheimer's. So please look carefully. Please do all the tests that Dr. Horowitz tells you are the right tests to do. Because, when people come in for cognitive decline, only one of two things is going to happen. Either we'll figure out what's going on and make them better, or they will die. So this is so critical to go in there and find the right thing.
What I think is fascinating about what you're finding, though, from what you told me earlier is, so at least in the initial ones by Kat Toops, it was like 4 out of 10 patients you were seeing with cognitive that had Lyme. Do you have a rough idea at this point, like in your population of cognitively impaired patients, how many actually have tick-borne? And again, it goes back to the testing because, for example, if there's at least 8 major species of Borrelia in the US, and I don't use a Lyme immunoblot from IGeneX, and I use an ELISA, I'm going to miss at least 50% of those cases. If they've got European strains, we're up to now 18 different species, right? So you obviously have to do the right test, but do you have a rough idea how many of the people in your clinic actually have it right now with toxins? Because that's really what we're seeing is reversing a lot of this cognitive decline. Is I treat with dapsone, we pull out the toxins. Of course, I get them to sleep and deal with mast cell and everything else, but it's ultimately the infections and toxins that are driving a lot of this immune dysfunction and inflammation. So how much do you actually see that you think is driving this whole epidemic?
Yeah, it's a great point. And because of the incomplete testing, we don't have a great number. So we have a minimum. My guess is when all is said and done, it is going to be around 40 or 50%. And here's why I say that. Partly because, Kat bothered to look more than most people do, and she saw that this is very common. And the other thing is, we've got a paper now that's going to come out showing long-term improvements. So, this has never been documented before, where you make someone better with Alzheimer's and then they stay better for years. We have people now over a decade who have continued to have sustained their improvement. Now, what we found when you look at these people, they will often get improved for 3, 4, 5, 6 years, and then they'll have some secondary decline. And when you look further, then you say, oh, wait a minute, now they have something we didn't pick up before. And one of the common things to find is a tick-borne illness that's kind of been going along there for a while, and you're able to handle it for a while, and now finally you're failing to handle that. Mm-hmm. And so now you treat that, and they come right back together. We had a great example recently of a woman who was on for 6 years and did great. Her 7th year, she started to have a re-decline, and she turned out to have mycotoxins. She turned out to have sleep apnea that hadn't been treated appropriately before, and she turned out to have some Bartonella. And so, you've got to look and you got to treat these things, and when you do that, you get better. And so, again, what we're seeing is that this disease, as I said earlier, it is a network insufficiency, but this insufficiency is driven by a chronic, mild, innate immune system encephalitis. That's really what's going on. And how often are these chronic, mild encephalitides driven by tick-borne illness? A lot, as you well know. Yeah. So I do think that, if you look at the top causes of cognitive decline, it is going to turn out to be metabolic syndrome, as you and I both know. This is a very common problem. There's somewhere around 80 million Americans who have this, and very addressable. It is tick-borne illnesses. It is mycotoxin and mold exposure, because what better way to goose up your innate immune system than to expose you to either molds and mycotoxins or to tick-borne illness? I mean, those are probably the two most common ways in our country to goose up your innate immune system. Right. With, of course, the other one being, vaccination with adjuvants. Right. So, that include adjuvants. So, that's an unfortunate one. Yeah, that one you really have to kind of weigh. What's the advantage? What's the disadvantage?
So Dale, if people have questions about, the things we're talking about today, want to get involved in your studies, how do they contact you or get involved?
Yeah, you can look at drbredesen.com. You can look at My Cognoscopy. We recommend everyone knows when you turn 40, you get a colonoscopy. If you are, or you turn 50, if you're 40 or over, please get a cognoscopy, because these problems sneak up on you. And just go to mycognoscopy.com. The other thing you can do is go to My CQ test. So you can do a free online test to see how your cognition is doing at My CQ test. Any of those.
CP is for cognitive performance?
A CQ.
Oh, CQ.
So CQ, yeah. So it's like an IQ. This is cognitive quotient. Exactly.
Cognitive IQ. Great. So question for you. That patient earlier that you said was stable for 6 to 7 years. My question is, with all the small particle pollution, 2.5, parts per million or less, that's now going on with the wildfires and COVID-19 getting up into people's brains, right? And the flu viruses, which have been associated with Parkinson's and neurodegenerative. How are we protecting people? I mean, you and I have discussed this a little bit before, but do you think there's a role for low-dose naltrexone to decrease microglial activation, for low-dose melatonin to stop NLRP3 inflammasomes, from maybe a touch of dapsone. I've always questioned this, just a little bit. What do you think is going to be the answer to protect people about what's going on with all of these insults?
Yeah, you bring up such a good point. And yes, I absolutely think, and we have many patients who are on low dose naltrexone, for example. And I think that your dapsone work is incredibly important. And I would like to see many of these people with Alzheimer's disease have a dapsone treatment because I think that many of them would do better with the dapsone. I love the combination. You're getting rid of the organisms, but you're also giving this anti-inflammatory effect. Because it's really interesting. If you look again at what is Alzheimer's, this has been my interest as a lab researcher for years. What is this thing we call Alzheimer's? And it really is this network insufficiency that's driven by a hyper response, which is why ApoE4 is such an important risk factor. About 2/3 of the people have it. And unfortunately, 75 million Americans are ApoE4 positive in the United States. So what happens is you are hyper responding to all these things that we get exposed to. You're hyper responding to your tick-borne illness. You're hyper responding to your mycotoxins. As you said, the California fires and other fires, obviously, with the little PM 2.5 particles. Now, there was something interesting, and I'm sure you saw this week, just came out that showed, this was from Emory, showing that if you look at people with PM 2.5 exposure, there was actually a bigger jump in the ApoE3s than the ApoE4s. So the people who don't have such a high risk for Alzheimer's clearly had their risk doubled when they got exposed to high levels of PM 2.5, whereas the ApoE4s are already at higher risk. So the increased risk was not so obvious because they're already at high risk. But the bottom line is this does come down to your response to these. And the more you're exposed, and the more you have a hyper response without clearing them. Now, if your response clears them on day one, hallelujah. But for most of us, of course, this is the problem. And this, by the way, is why it's these chronic infections like tick-borne illnesses that increase your risk for Alzheimer's disease. You get pneumococcal pneumonia, you clear it with amoxicillin in a couple of days or whatever you take, cephalosporins, what have you, you don't have an increased risk. So it's these chronic infections, chronic toxin exposures, changes in microbiome that give you this long-term activation of the innate immune system that includes making amyloid.
Right. And they've shown in the literature, I mean, for people who don't obviously follow this literature like you and I do every day, that Borrelia burgdorferi co-localizes with amyloid in the brain. And there's been about 7 or 8 studies by Judith McCloskey from Switzerland, Alan McDonald, showing there's a direct link as a spirochetal infection like syphilis, right, that relates to Alzheimer's. But of course, the problem is in figuring it out. It's also herpes virus 1 and 2, right? And it's herpes virus 7 and 8, and it's Propionibacterium and Porphyromonas gingivalis and H. pylori, chlamydia pneumonia. There's so many bugs that seem like they cause an inflammatory response. It's difficult sometimes to tease it out, although the dapsone part that's really fascinating for me is my patients obviously have all these other things, but the amount of cognitive improvement and all the studies we published, the cognitive improvement on dapsone approaches about 70%. It's the number one thing that gets better in Lyme patients with dapsone. And you and I have discussed this before. There were 3 studies on dapsone, one in mice, showing that the hippocampus, it lowered inflammation, increased nitric oxide in a mouse model, showing the memory improved. They had a 15-year study in Korea where the people with leprosy who took dapsone, the ones who took it, the Alzheimer's rates were like 7 times less than the ones who didn't. And then there was a randomized double-blind placebo-controlled study about 201 people. This was a couple of years back that also showed that just 100 milligrams of dapsone, it reversed mild cognitive improvement. Now, the question is, how many of those patients who took it actually had Lyme, or did it act as a neuroinflammasome inhibitor, just lowering inflammation in the brain, having nothing to do with it? That's going to be one of the big questions we've got to answer as we go forward.
Yeah, absolutely. And as you mentioned, you look inside these amyloid plaques, and they've always been seen as, oh, your protein misfolded. I mean, this is such an outdated concept. Your brain, when it is assaulted by these various things, produces the amyloid as a sequestrant and as an antimicrobial peptide.
Mhm.
And so whether it's Borrelia or whether it's HSV1, as you mentioned earlier, what have you, it actually works quite well as an antiviral, as an anti-parasitic. I mean, it's kind of remarkable. And then, of course, you have other things that you make. Alpha-synuclein, which we associate with Lewy body disease and Parkinson's, is also an antimicrobial peptide. So you see this same sort of thing. And by the way, so is tau. These are all antimicrobial peptides. It's showing that your brain is responding to these insults that are coming your way. And so I think we're going to get better and better about understanding what's inside of those. And you're absolutely right. Dapsone probably should be a part of everyone's treatment for Alzheimer's. And I think someday it probably will be. People have been concerned because in the past, it's been associated with many side effects like, like as you've pointed out, like anemia. So we just have to kind of get it, where do we use it? When do we use it? On which people do we use it? Do we do it on everyone? But absolutely things like Dapsone and LDN and other anti-inflammatory approaches. It's interesting to me that some of the people who have mast cell respond to things like anti-CGRP, things like Nurtec and Ubrelvy and things like that.
For the migraines, yeah.
So yeah, so migraine drugs basically, yeah. So I think we're understanding much better this idea of what's driving this disease as opposed to just, oh, some protein chose to misfold and now we got a disease.
And you and I have talked about this earlier, but the part that made no sense, and you started off our conversation today like this with the medical system, is how do you possibly name a disease and then give people Namenda and Aricept or lecanemab and try and pull out amyloid with 15 to 20% brain bleeds when you have not gotten to the source of why the amyloid is being produced in the first place or the tau is being produced, right? It's like, it's just a backwards approach. You're not getting to the sources, that you have found and that I have found, which in fact our models, you and I hadn't met until just a couple of years back. And our models basically came to the exact same conclusion,
Right.
Multiple sources of inflammation, downstream effects, right, with energy requirements that is driving a lot of these chronic illnesses.
Yeah, and this is where I think this is the difference between 21st century medicine and 20th century medicine. And unfortunately, 20th century medicine is still being practiced by the vast majority of physicians, unfortunately. So, you go back to the dark ages where people say, oh, this person got a cough, because they stepped on a line yesterday or because they did something wrong. They said a bad word about their mother-in-law or something. And that's why they're
Did you
dying.
hear me say something about? I'm sorry, I take that back.
Yeah.
Mom, I'm sorry if you accidentally heard that.
Yeah. So,
No, it's true. I mean, it's just not it. We really need a complete paradigm shift in the way we're dealing. Acute diseases, we've got it nailed, but chronic diseases, there's a paradigm shift that needs to be approached as far as the sources and downstream inflammation that's making people sick.
Well, isn't this interesting? 114 years ago, it was 1910, I believe, was the Flexner Report. And the whole idea of the Flexner Report was to go out and say, you know what, we need to have more basic science to understand the medicine that we are doing. Just doing stuff for no reason doesn't make sense. Well, we need a new Flexner Report, an update to say, look, it's not about a protein decided to misfold. It is about what's causing these things these are physiological responses that ultimately become pathophysiological. And we need to identify these and treat it. And by the way, as you well know, when you do, you see unprecedented improvements in complex chronic illnesses, be they long COVID or tick-borne illnesses or Alzheimer's disease.
No, I think we're definitely going towards a revolution in medicine. And ultimately, we have to, because the healthcare costs at this point, 86% of our healthcare costs in the US are due to chronic disease. 70% of the deaths in the US are due to chronic disease. 50% of Americans have at least one chronic illness or more. It's like, so you go to your doctor and it's like, go for your prostate exam, your colonoscopy, your mammography, check your cholesterol. But nobody's doing what you just talked about with the CQ, which is, gee, at 40, maybe we should be checking your cognitive, IQ, checking for Lyme and tick-borne, looking for toxins, looking for insulin resistance, like knowing that so many people are going to get Alzheimer's, 15% of the US population is going to disable the healthcare system and basically everything we're doing.
Yeah.
We should be starting now in a screening approach with all doctors. And you don't see primary care doctors really taking on that approach of looking for all these infections and toxins and treating it.
Yeah, it's a really good point. And you have to change the way you practice medicine and change the way you think about pathophysiology. My argument is Alzheimer's for the first time is now optional. If you just check when you're 40, see where you stand, get on the right prevention, virtually nobody needs to get this disease. People will turn out to, they're going to find out, oh, you know what? I am brewing a tick-borne illness. I didn't realize it. Or I do have a fairly high exposure to mycotoxins. Or I do have sleep apnea I was unaware of. Or I do have some dysbiosis I was unaware of. Or my mercury level is quite high and I was unaware of that. These are the sorts of things that can make a huge difference, literally the difference between life and death. So I do think, this is the future of medicine, to do much more ahead of time. And people have talked about prevention forever, but we're understanding better and better about what you actually have to do to get very, very good prevention of these complex chronic illnesses.
Regarding that, I've kind of wondered with the way the healthcare system works with payers is that whether, and I've questioned this, whether instead of just having centers for chronic disease management, which I think we are going to need at some point because it's getting, but even prevention, where you take something off your insurance policy, like if you go to your prevention doctor, but you actually do the right diet, keeping down the carbs, getting on ketogenic diets, exercising every day, getting enough sleep, you're going to prevent your chronic illness, getting your blood pressure under control, but most people, unfortunately, I mean, some of us do, but it's not happening enough. And I'm wondering whether we need a financial incentive where people go to these prevention centers, you prove you go there, you hit certain milestones, and you get money off your insurance because you're going to save it down the road, right, for the entire healthcare industry.
It's a great point. And, that was what was accountable care was supposed to be about,
Mm-hmm.
but we've just never gotten there. And because just as, Robert Lustig points out in his book, Metabolical, which I love, he goes into this and says, look, we're dealing with big pharma, big food, and big medicine and healthcare. And these are the ones that are taking the money. And therefore, there's no incentive, and there's actually a disincentive to do the right thing. So there has been a lot of suppression of good medicine. I hate to sound, I hate to sound the alarms, but the reality is we have a suboptimal medical system. Anybody who looks for 2 seconds at it can understand that. And as people have said frequently, medicine is broken. And it's really because the model we have for medical care is based on treatment of acute illnesses. But now we are all dying of chronic illnesses. So the system it's like we set up a system to play checkers, but now we're playing chess. It just doesn't work the same. And so we do have to have a fundamental reorganization, an overhaul of the medical system. And there's no incentive for current payers to do that.
Right. So question for you, when someone's trying to get diagnosed these days, I know that there are biomarkers with amyloid beta and phosphorylated tau and glial fibrillary acid protein, a new one, formic acid came out. When apart from the ApoE4, when you want to take a look at what is really my risk, what's going on, people can't afford F-18 PET scans. What are you doing to actually give them a risk analysis at this point?
Yeah, great point. And we actually have something called RECODE reports. So we look at all these things. But the critical piece here is that there are two different parts of this. What's your current status? Are you beginning the changes? So this would be like looking at someone who has insulin resistance. You want to know what's your status. Are you at insulin resistance? Are you at pre-diabetes? Are you at full-on type 2 diabetes? The same thing here. So we're literally changing from the dark ages to a golden age where now we should be able to prevent this and reverse it in virtually everybody if they just come in relatively early. So the tests that are good for if you have it are different than why you have it. Mm-hmm. And so for the if you have it, there are new blood tests, as you mentioned. Phospho-tau 217 is the best of them. It is sensitive. It has a huge dynamic range. When you have abnormalities, it goes up fourfold. Whereas your A beta 42/40 ratio, which is another one that's out there, it goes down by 10%. It's a very tiny dynamic range. So I really like the phospho-tau 217. Now you complement that because that is specifically for Alzheimer change in signaling. It's exactly what we've talked about. You go from this synaptoblastic signaling, making synapses, to synaptoclastic signaling. You're literally switching from connection to protection because you got a tick-borne illness or you got a poor oral microbiome, what have you. You're switching to a different mode in your brain, which is associated with inflammation. Then you complement that with GFAP, which is glial fibrillary acidic protein. That is not specific for Alzheimer's, but highly sensitive for any sort of changes in the brain. It is looking at astroglial activation. And then the third one of the triad is NFL, neurofilament light. And that's looking specifically at neural damage, but not necessarily Alzheimer's. So you can then look at the pattern. So if your p-tau is normal, your NFL is high, you probably have something like ALS, frontotemporal dementia, you had a bad car wreck, something like that. It's not Alzheimer's. If your p-tau is high and your NFL is not so high, you've got Alzheimer's, but you don't have a lot of ongoing damage. You're still doing fairly well. If they're both high, be careful. You're headed down a bad pathway. So that's if you have it. Now, why you have it, again, that goes back to just what you and I have talked about. You want to look at what's my status with inflammation. And you can do that so simply. HSCRP is a great way. It's not terribly sensitive, but it's a good way to start. Albumin to globulin ratio is an ancient way to look at this, and yet it's a pretty sensitive way. You can look at things like TNF alpha and things like that, IL-6 and things like that. But even just getting the HSCRP, then you want to know your glucose status, and so you want to have your hemoglobin A1C, your fasting insulin, so you could get a HOMA-IR, of course, in fasting glucose. If you're really concerned about that, then you want to do a GTT and check insulin levels. But for most people, you don't need to do that. Then you want to know, am I atrophic? Have I reduced my B12, my vitamin D, my estradiol? So all the things that are neurotrophic, and those are three kinds. They're growth factors like NGF and BDNF, hormones like estradiol and testosterone and things like that, and nutrients, vitamin D, vitamin B12, things like that. You want to look at those. Then you want to look at your toxins and your infections, just as you well know. And that's, to me, where the trickery comes in, because it is tough. That's why we need experts like you who say, look, this test is not good enough. You need to go to this test. And why your MSIDS is so helpful, to be looking at am I concerned about this, or is this not such a big concern? Right. So those are the tests that you need to do to determine what's going on. And for the toxins, we include, again, three types. It's the heavy metals, it's the organics like glyphosate and toluene and benzene and formaldehyde, and it's the biotoxins like trichothecenes and ochratoxin A and things like this. These are the three big bad actors in terms of cognitive decline. So once you've looked at those, now you know if and why.
And Dale, one quick question. When you're doing the heavy metals, because they don't stay in the blood for very long,
Yeah.
Are you just doing serum levels, or do you occasionally do hair analysis, 6-hour urine DMSA? How are you checking for it?
Great point. And it depends on whether you're suspicious of this. Yes, it would be great to do $1 million workup on everybody, but you can't. And so what we typically do is we do a screen, and then we also, from the history, look and see, does this person have amalgams? Do they eat a ton of fish? That sort of thing. We had a guy several years ago who had extremely high mercury levels, and he'd already been told, you got Alzheimer's, you're going to die, et cetera, et cetera. It turned out he had extremely high levels, and then he was treated for that and did very well, and then was treated beyond that, turned out also to have biotoxin. So it's a good screening. But you're right. If there's a suspicion, a lot of people like to do urinary tests and like to do provoke tests, like a doctor's data, something like that. Some people like to do the Chris Shade's quicksilver test, and which does he has the tri-test, which does include urine, hair, and blood. What I like about Chris's approach is that will now tell you, are you a good excreter? It will tell you, is this mostly organic? You probably got it from seafood. Is this mostly inorganic? You probably got it from dental amalgams or things like that. And again, as you lose your ability to excrete this, now you do more and more poorly as this now starts to build up, which is why I like to look at things like, how good are you with detox?
Right. And of course, as functional medicine practitioners, we're looking at the phase one, phase two pathways all the time in these patients, because some of my patients, their detox pathways are just basically overwhelmed. And, they come in with low serum glutathione levels. They need a lot of NAC supplementation.
Yep.
I mean, clearly they need help. So, what I find interesting, and the reason I'd love at some point, we've talked about collaborating, is when I started doing my research on Alzheimer's and neurodegenerative, and I looked up the drugs I'm using in the dapsone protocol, it was like tetracyclines lower amyloid beta. It's like, oh, I didn't know that. Rifampin lowers amyloid beta. It's like, oh. Dapsone decrease amyloid deposition. Methylene blue increases tau degradation and amyloid beta levels. Like, hold on here. All the stuff that I'm using for dapsone for Lyme is
Yeah.
affecting amyloid and tau. I mean, I didn't even know it until I started diving into the literature. This is why I think in people who are established, right, who already have it, where we know they have tick-borne, I think it's going to be really fascinating to do a dapsone trial on these people to find out, even if they've got, some of the damage that's already there, can we at least get them to a more functional status, right, because of how bad it gets towards the end of the illness.
Yeah, exactly. And the same thing could be said for curcumin. That's another one that lowers. Cat's claw is another good one that lowers this. Ginger. Why do these things do it? Because they are either anti-inflammatory or they're actually getting rid of things that are inflammatory. So one way or another, this all fits together. And this is what I love about functional medicine. It actually makes sense. There's internal consistency. It doesn't say, you tripped over something and a protein misfolded and it killed you. That's not the way physiology works. These things are not there to kill you. They're there because they're trying to help you. They're trying to respond to an insult that you had. And unfortunately, of course, we're living in a world that's full of insults. From the way we build buildings with mold food, to the way we go out in the woods, get ticks on us, and don't realize we've got this, and don't bother to check while we're getting all these symptoms. So that's why I love your ballad of the deer tick. It's I still smile about that every time I think about it. It's great.
Yeah, no, I'm glad you enjoyed it. So for you to do prevention, I mean, you're probably doing what I'm doing. I mean, I'm on my treadmill literally 7 days a week at a 12% incline. I get to sleep by
Wow.
10 o'clock. I've got my diet as good as I can. I have the nosh gene, unfortunately, a little bit. So I have to be careful with my noshing.
Yeah,
But
I got you.
I do take LDN. I block NF-kappa B with NAC glutathione, alpha lipoic acid, which helps with insulin resistance. I take curcumin. I take broccoli seed extract. I take resveratrol. So are you doing a lot of these things? And is there enough, like with the Framingham study they did years ago, looking at, all these nurses? Do we have any evidence at this point for people like me that are swallowing a lot of things and really trying to stay alive on the planet as good as health as possible, that we will live longer and maybe not get dementia, Alzheimer's, and neurodegenerative? Do we have any long-term studies at this point, or it's
So
anecdotal?
these long-term studies take a long term, as you well know, and so I'd say that the best data we have to say that when these things that you're dealing with are risk factors. So yes, for example, you look at the finger study. That's one that looked at just four things, just some basics like dealing with some vascular parameters, very, very helpful to people. But no, you're right. There's no perfect, Framingham study yet to say we don't. If you take this, you won't get it. What we can say is, I would say, some of the better ones, like the Rush study. Rush is doing a great job in Chicago with many different brain autopsies, looking at all what's happened, what gives you more likely, less likely to have problems. And there have been several papers published on looking at some of these different things, looking, for example, at orthostatic hypotension turned out to be one of the risk factors. Of course, poor sleep, of course, things like smoking. To me, this is why having an accurate theory of what's going on is so valuable and important, because that tells us you don't have to do a zillion experiments. You can pretty much predict, and then you can, if you want to show that with experimentation, great, but you can pretty much show these are the things that give you the very things that your brain is responding to give you Alzheimer's. So yes, if you don't perfuse your brain, that's not a good thing. If you've got chronic inflammation, that's not a good thing. If you've got horrible sleep, the sort of things that you were talking about. And that is why, I do believe in things like curcumin and cat's claw, and getting exercise every day. It's remarkable what exercise does for you. And where we really see it is in people who jump on EWAT, exercise
Right.
with oxygen therapy, have gotten some very, very nice results.
And
And
and I think the numbers you're quoting on Alzheimer's are neurodegenerative with because you were talking about hypoperfusion.
yeah,
The Lyme patient population, we're seeing at least 40% of our patients now getting POTS dysautonomia with low blood pressure.
wow,
We know
yeah,
that long COVID, of course, is causing it and is like, 50 million people worldwide. I mean, really, we're talking about huge numbers of people now that may be hypoperfusing at this point.
yeah,
And we have people do sitting and standing blood pressure and pulse rates to show it. People know, I stand up, I get dizzy, I pre-syncopal, I feel like I'm going to pass out. I do pass out. I mean, there's certain clinical clues, but that sounds like it's even going to be an overlapping risk factor we may not have had years ago because of both long COVID and chronic Lyme, both
yeah.
causing POTS and low blood pressure with low perfusion these days.
And what's the biochemistry? Why are so many people getting POTS?
The best I've been able to come up with both long COVID and chronic Lyme is what I describe it as the three I's: that infection, immune dysfunction, and inflammation. So whether the infection is Borrelia burgdorferi or the infection was COVID-19, it's
Yeah,
basically causing an inflammatory response with immune dysfunction. And what happens is the autonomic nervous system, with neuropathy, you get an autonomic neuropathy in Lyme, you get an autonomic neuropathy with long COVID from the inflammatory response affecting the vagus nerve and affecting that part of your body. So it's infection, inflammation, and immune dysfunction. Just the infection is different, but the end stream effects seem to be the same. That's the best I've been able to come up with as to why so many people are getting it.
this is so interesting to me because, when I was training many, many years ago, there was a disease called Shy-Drager disease. I'm sure you remember this.
Right.
This is an
For
autonomic,
Parkinson's, where they would pass out.
and it's an autonomic dysfunction, and you can get it with the Parkinson's or without the Parkinson's. And this is now called multiple system atrophy.
Mhm.
And I really think, again, nobody knows what causes multiple system atrophy. It's a horrible disease, and I think that it's likely it's going to turn about to be just the things you're talking about. It's tick-borne things, and it's infections and long COVID and things like that that are damaging this autonomic response.
Yeah. And the one that in our practice that is really coming to light in the last like decade is Bartonella, which you and I were just talking earlier. Like you're starting to find it in occasional people. If you think Lyme has been a stealth pathogen, this one's even worse because there's at least 17 pathogenic species. You can't get a regular test. You can't just rely on Bartonella henselae, Bartonella quintana, Bartonella bacilliformis from Quest or LabCorp. You need specialized laboratories with fish testing or direct droplet PCRs from Galaxy or from IGeneX or from TLA, very specialized labs. And I will tell you, because they're not sure if it's tick transmitted, there was only one study in Europe in Ixodes ricinus ticks that transmitted Bartonella burgdorferi, a specific species. But almost every Lyme patient now that's coming in is being exposed to Bartonella, and it's an intracellular chronic pathogen driving inflammation, causing the same symptoms as Lyme and causing cognitive dysfunction. So, even the question becomes, and, the people you're seeing, and I'd love to look, of course, at how you're doing the screenings, and maybe you and I can collaborate on this. I would love to find out in some of your resistant patients that are not responding to the MIND diet and, to all these great things that you have published in your New York Times bestselling book. And by the way, please let people know they really do need to just give them a quick, you're allowed to do a quick promotion here. Just tell people about your book because they really do need to read it.
Yeah, so we've written three books now. The End of Alzheimer's, so named by the publisher, actually. The End of Alzheimer's Program, because people said, well, we want more details on the program. And then the third one, which was called The First Survivors of Alzheimer's. And just 7 wonderful stories from people who were all told they were going to die. They all did great. They're still doing great. And I asked them to write their own stories. And it's just, if you can get through that without getting a little choked up, you're a stronger man than I, or
Um,
woman
I,
than I.
I just interviewed 18 people with dapsone combination therapy.
Yeah.
Um, and we've got this will be shown during the Healing from Lyme Summit. And I got to tell you, the stories also, they're amazing. They give hope, just like your program is giving hope to people that this is not necessarily a death sentence and, down a certain road. It's the same thing with Dapsone. We're finding that we really do have answers for people. And it's so fascinating that you and I have been working at this from opposite ends. You're coming at it obviously from the brain. I'm coming at it from, my perspective, but we both came up with exactly the same conclusions of multisystemic, different forms of inflammation driving downstream effects with basically infections, immune dysfunction, inflammation, right? Causing the same problems, whether it's the brain or the heart or the bones, the joints, whatever I'm seeing in Lyme. But getting back to Bart, I think it's going to be one of these things you're going to find when you start looking at some of these resistant patients. You may be actually surprised. It'd be good clinically to check out some of your patients if they've got these stretch marks, these classic striae that are now starting to show up. It's in mostly the people with neuropsychiatric symptoms, but more and more when I'm doing a full physical and I'm looking, they're either perpendicular to the skin planes or horizontal, but they almost look like you gained and lost weight. They are a clinical sign of BART, just like an EM rash would be a sign of Lyme. So, with markers like VEGF, vascular endothelial growth factor, which, COVID also can stimulate. Although when I spoke to Bruce Patterson, I said to Bruce, how do you know, though, the virus is actually not stimulating an underlying BART infection from reactivating in some of these people? Because, he's looking at CCL5 and all these TNF alpha and all these inflammatory markers. VEGF is one of them. It's showing up in long COVID, but it's the one we use for BART. And I'm kind of wondering if you start looking at, some of your Alzheimer's population, it might really be interesting to see in the ones that don't respond. So all this great stuff that, you're doing, maybe BART, is going to be one of these underlying factors. That's what we're finding in our practice right now.
And I would guess that that's one that's completely under-tested for. As you pointed out, virtually impossible to get all the, to have the right test for this.
Yeah.
I would be, and by the way, let me tell you a quick story. We had a person with posterior cortical atrophy, which is 5 to 10% of Alzheimer's, presents with this visual analysis problem, visual perception problems. This is a patient who worked with a wonderful health coach in New York, Carrie Mills Rutland, who works with me. And so we routinely go over various patients. And this person could not read anymore, could not use the computer. And this person ended up couldn't do any of the brain training or any of that stuff. You got on the right program, started doing better, and it turned out she had, as one of three major things, Bartonella. She had some unusual leg pain, interestingly. And she actually consulted with Dr. Neil Nathan, your colleague and friend, and she was treated for this. And now she is using the computer. She is reading once again. She's doing brain training again. And her MRI, her parietal lobe volume went from 0.5%, less than 1 percentile, to the 22nd percentile. So just striking improvements in her MRI over a year.
Just treating the infection with Bartonella.
Well, she was on the whole protocol, but
okay.
Treatment of that. So she was, doing all the right things to get that supply up and the demand down, and she's done very well.
Yeah.
So, again, Bartonella, you're right. I think it's way more. It's out there more than we realize.
Yeah. Dale, believe it or not, we've just reached I feel like I could be staying on the phone, honestly, and these Zoom calls with you for hours because you and I have so much to discuss on this. But I look forward to really a collaboration. I think it'll be fascinating. Any of the boards you need me on to take a look at the trials, help with it, I am more than happy to help out because, at this stage in my career, just like you, when I'm doing one-on-one, but I think we're here to benefit the larger population of the people who really need us because of the dire situation the world is with these neurocognitive deficits. So congratulations on all the great work you're doing. And it's really been a great pleasure to speak to you. So just before we come off, one more time, how do people get in touch with you and take that CQ test? Just tell them again, best ways.
You just go to mycqtest.com. My CQ test, easy to do. You can go to drbredesen.com. You can follow up Facebook, Dr. Dale Bredesen, Twitter, the usual X. I mean, now that that's changed, the usual sorts of channels. And take the test, see where you stand. It's an easy thing to do. And then please, if you are 40 or over, get a cognoscopy, get on active prevention so that we can all reduce the global burden of dementia.
So I have not used the word cognoscopy in my lexicon for vocabulary up until now, but I think my lexicon is about. I love that word of getting it. So it's wonderful. It's definitely being added in. So Dale, thank you so much for taking the time today. For those of you who've been tuning in, my name is Dr. Richard Horowitz. I'm co-host of the Healing from Lyme Summit. We've just had an amazing talk with Dr. Dale Bredesen. Dale, thank you for all the work you're doing. I look forward to us collaborating in the future, and just keep up the great work.
And you as well. Thank you very much, Richard. Take care.
My pleasure. Good seeing you.
Good seeing you. Bye-bye.